Okay, we're now live. This is the monthly quiz. As Lily said, this is the third Thursday of the month. It's hard to believe we're the third anything. January just started and now it's half over. Anyway, here we go. Okay, so I got a dozen cases for you. Let's get started. Acute abdomen and FUO, what you notice right away is in the liver there's linear densities, which are actually air in venous structures, right? That's the key finding. The patient has portal venous gas. When I see portal venous gas, I got to be thinking about ischemic bowel, though there are other reasons, including iatrogenic causes. As we scan downward, you can see pneumatosis in multiple bowel loops. Using a kind of lung window is very helpful. There's also pneumatosis in the patient's cecum. And you can see in the coronal view the pneumatosis in the cecum. You can see pneumatosis in a distal small bowel loop and multiple small bowel loops. This appearance is most consistent with ischemic colitis. And with the air in the portal venous system, you have to worry about bowel infarction. And this patient indeed had transmural gangrenous necrosis of the terminal ileum with air in the portal venous system and infarction of bowel. These patients have a high mortality rate. Again, these patients will do poorly. It used to be said that patients with portal venous air would always die, but that's not always the case, but they always will have a very difficult course. So a really nice example. Fever. When I look at this case, you say, well, the small bowel's not dilated, but what's going on in the root of the mesentery? We'll look more carefully. There's a nodal mass. The nodal mass is of low CT attenuation in part. There's calcification present. Could this be lymphoma? Could it be a carcinoid? Low density nodes are more common in things like testicular or germ cell tumors, also in Whipple's disease, also in infection, also in treated lymphoma. When I say infection, I typically think about MAI infection. There's the mass in the root of the mesentery, seen nicely on the coronal view. The bowel looks good. I don't see any other masses present. This eventually was worked up and biopsied, and this was MAI with cystic mesenteric nodes. A really nice example. GI bleed. Well, what do you see on these images? Looks like lung mets and liver mets and splenic lesions. And look at the subcutaneous tissues. You see multiple nodules present. And as I scan further, there are masses in the left paraspinal muscle. When you look really hard, there are nodules in the patient's small bowel, as well as that subcutaneous nodules. Liver mets, small bowel masses, multiple nodules in subcutaneous tissues, as well as in muscle. Now you're talking about disease in multiple organs. What's your diagnosis? Well, you could think about lymphoma. That's always the thought, multi-organ involvement, liver, spleen, kidneys, and other images showed pancreas as well as the bowel. But when I see so many subcutaneous nodules, I got to be thinking about melanoma. Melanoma gives subcutaneous nodules, masses in muscle, liver, spleen, bowel, you name it. And this was an excellent example of metastatic melanoma. And remember, we think about primary tumors as the cause of GI bleeding when we think about tumors, but you also need to think about metastases such as melanoma and renal cell carcinoma, to name two of the most popular ones. FUO, I see the spleen is enlarged. There's patchy enhancement, there's subcrural nodes and para-aortic nodes. As I scan down with the patchy enhancement of a very enlarged spleen, as well as extensive adenopathy. I think all of us are the same. There's a lot of reasons for a big spleen, from mono to lymphoma. There's many reasons for nodes. But when you see bulky nodes and mesenteric nodes, and you see a large spleen with what looks like splenic infiltration, you got to be thinking about lymphoma. Here's the cinematic, the infiltration of the spleen, very nicely shown on these images. And this ended up being Hodgkin's lymphoma. It was EBV positive, but a nice example. So Big spleen, there are benign causes, mononucleosis, thalassemia, but big spleen, particularly with infiltration, and then when you get nodes, you're pushing to lymphoma. Could be many other things, metastasis, could be melanoma, could be fooled with sarcoid at times, but a really nice example of that splenic infiltration. Abdominal pain. There's a large mass involving small bowel, which is exophytic. The best diagnosis should be a GIST tumor. We'll look at it again. The small bowel is not dilated, not obstructed, but there's a large mass. So you could think about lymphoma, adenocarcinoma, could be a GIST tumor, and I probably would pick GIST because it's eccentric. GISTs are commonly eccentric, which is why it's not obstructing. But yes, it could be lymphoma, could be a primary tumor, or it could be metastasis. This ended up being biopsied, of course, and this was a Merkel cell tumor. Merkel cell tumors can metastasize many areas, including small bowel. Remember, small bowel mets, you think of melanoma, you think of renal cell. Merkel cell tumors are rare, but they're fairly aggressive. Very aggressive tumor, and small bowel metastasis is one of its patterns. Okay, anemia. What do I see? If you look really hard with a good imagination, there's something in that small bowel loop anteriorly to left of midline, which you can see a bit better toward the left of midline inferiorly on the coronal views. And when you narrow the 3D images, you can see the mass is smooth. It's round and it's high density. Could it be a metabowel like a renal cell? Could it be a GIST tumor? Could it be a carcinoid tumor? Those are all really good possibilities. Doesn't have the look of adenocarcinoma. This was resected, and just to show you how difficult life is, this was a small bowel schwannoma. Schwannomas are rare in the small bowel, but they're often of low CT attenuation because they're neurogenic tumors. This was a smooth vascular tumor, and I would have thought about GIST, I would have thought about carcinoid as my likely diagnoses. Patient with hypertension. Well, big mass left adrenal. It's cystic and it's solid. Interestingly, it's not very vascular. When you have hypertension, you got to think about pheos. Most pheos are very vascular, but not always. Also, adrenal cortical carcinoma is a consideration. Aldosterinomas can be malignant, so that would be a thought as well. Metastasis, but there's no known primary, and that usually does not present as hypertension. This was resected and was a cystic pheochromocytoma. Pheos can be cystic, but typically are more vascular. This wasn't vascular. It's kind of an atypical look for a pheochromocytoma. What about this case? Possible pancreatic mass. And there is a 1 centimeter vascular lesion in the body of the pancreas, better seen here. Vascular lesions in the pancreas, yes, it could be metastatic renal, but the kidneys look good. So it's typically a neuroendocrine tumor. They can be small, they can be large, they can be single or multiple, they can be incidental or syndromic, like with MEN1. And you can see it very nicely on the volume rendering and on the MIP imaging. And this was MEN1 in a patient with a neuroendocrine tumor. Very nice example. Another case, abdominal pain, vascular lesion, dome of liver, could be hemangioma, could be FNH, could also be metastatic disease from a vascular tumor, like a neuroendocrine tumor. Here you can see the mass, a very nice mass, 3.2 centimeters. Very, very nice example of a very vascular lesion. When you look on the coronal view, you see the primary mass and a secondary mass. These are multiple neuroendocrine tumors, beautifully shown on the cinematic rendering. Another patient with MEN1. So you can see MEN is associated with neuroendocrine tumors, which can be small or large, can be single or multiple. So very important to look carefully, as in this case shows very nice example of multiple lesions. Left upper quadrant pain. There's something going on in the chest wall. There's inflammation pushing on the diaphragm, growing through the chest wall. It's kind of cystic. You could think about tumor, but when it's cystic like that, you got to think about infection. What infection is there that involves the chest wall that's both anterior and posterior to the ribs? It's kind of a classic actinomycosis, right? Yes, it could be E. coli that can cause infections. Yes, you have to think about tumor in this case, but this was a wonderful example of actinomycosis, which I quizzed Stefan on yesterday. Patient hypotensive. Patient came in hypotensive. You can see heroic measures were made. There's infiltration of the left ventricle. It's markedly thickened. What's causing left ventricular thickening? Could be amyloid, but it's more on the superior portion. We see the thickening. And then as you go in the abdomen, another good look on the cinematic of the thickened LV wall. But the patient also has enlargement of the adrenal glands. And you see the left adrenal vest here. There's also infiltration of the pancreas, but also better seen here, the kidneys, where both are infiltrated. There's nodes in the mesentery. So what gives you infiltration of the heart, infiltration of adrenals, infiltration of kidneys? That's going to be lymphoma. And this was a great case of cardiac lymphoma and renal lymphoma and extension beyond those organs as well in this patient who arrested. Also very nicely shows you the infiltration on the cinematic rendering, a really nice example. Now this may be the last case, chest pain. When you look at the LAD. There's an aneurysm of the LAD partially calcified. It's a large aneurysm, nicely shown. Now you can get aneurysms from atherosclerotic disease. This patient was young. What gives you aneurysms in young patients? What gives you multiple aneurysms? Though I admit I only see one, but let's say I told you there were 3 or 2. What is it? It's Kawasaki's disease. So a nice example of Kawasaki's disease and an LAD aneurysm. So that's a dozen cases. I hope you enjoyed them. Go back, look at them again, think of the differentials, think of everything. And after you finish thinking, have a great day, everybody. Thanks a lot.